Howdy, everyone. I'm David Glazer. I'm here with my colleagues, Catherine London.
Hi, everyone.
Pari Magera.
Hi.
And Marguerite Amon.
Hello.
And we are going to go through the regulatory update, sort of what's in the Medicare fee schedule, the inpatient prospective payment rules. At the end, Margie's going to do something really important and talk about the new support law, which sort of snuck through. I know I didn't hear much about it, but is kind of a big deal. Before we dive in, just a handful of announcements. So first, we've taken the plunge. We're on Twitter, and our wittiest lawyer, Breyer, is running it. And I don't know if she's done anything funny yet, but she's funny. You can follow us at Fred Health Law. So if you're a Twitter person, I am not. Fred Health Law will get you there. Second, the January webinar was going to be a week later than normal. It'll be January 16th. And the topic is digital health and emerging healthcare technologies. So they'll talk about artificial intelligence, blockchain. I know for me, I don't know what blockchain is. I've never understood the term, big data. So Ryan Johnson will be doing that and maybe joined with a colleague, cybersecurity, that kind of stuff. In February, on the 13th, it's almost certain we will be doing provider-based. The only caveat is we're expecting new guidance to be issued early next year on provider-based stuff. There was a webinar last week, 2 weeks ago, that the AHLA did where they announced that some of the space sharing enforcement positions that the government has taken, and we would say taken incorrectly, are going to be revised. And assuming that happens, we will, in February, talk about them and other provider-based stuff. So I will now dive in with, I only want to mention one other thing, which is I want to congratulate Pari, actually did a jury trial with a colleague, Pam Abate Datillo, on a sex harassment and retaliation claim for one of our healthcare clients and won it, and that's always exciting. So what are we going to talk about? We've already covered that, so we'll move right in. The big things, the Federal Register has the final rule from November 1st. They're going to talk about the conversion factor as it's changing. Do you want to chime in on this at all? As basically notable changes we'll go through.
Yep, these are all topics that we will cover shortly.
Okay, E&M. This may be the biggest. In 2021, there is going to be a dramatic change to the way evaluation and management services are covered, or I guess reimbursed by Medicare. So first, obvious thing, everything we're going to talk about today is Medicare specific. Well, almost everything. There's the support exception. Everything else is Medicare specific. So what the biggest change in 2021, and this is only going to apply in the office. It doesn't apply to hospital, to critical care, so it's not all E&M, only office visits for new and established patients. Basically, we're going to create 3 payment rates: 99211, a nurse visit, 212, and actually this applies for both established and new patients, so 202 or 212 through 212, or through 214 or 204. So level 2 or level 4 office visits are all going to get paid at the same rate, regardless of what you do. And this is really crazy. And there's still going to be a 5. You can have a level 5 office visit for newer established patients, and those will be reimbursed. But otherwise, one level of reimbursement, whether it's a 2, 3, or 4, and we'll talk about what that level of reimbursement is at the same in a minute. They're expecting you, it appears, to still pick a code, but you get paid the same whether you picked a 2 or a 4. This is kind of crazy. It's not kind of crazy. This is crazy. And if you do enough work to support a 2, you will get paid the same as if you do enough work to support a 4. So that's the bottom line there. Now this is not till 2021. In 2021, you get to choose whether you're using the 1995 guidelines, the 1997 guidelines, time, or medical decision making. You can pick any one of the 4. If any one of the 4 gets you to the level that you want to be at, you're good to go. That's also a little interesting. Medical decision-making, I occasionally see people get confused on the difference between medical decision-making and medical necessity. It is weird that they're focusing on medical decision-making. Hopefully, people who do coding know there are 3 key components: history, exam, and medical decision-making. That's one of the 3. So what they're kind of saying is you could ignore the history and the exam. I suspect that a major driver there is that note bloat, the fact that electronic medical records make it so easy to have an extensive, especially history, means they're kind of saying we don't care about histories anymore. We think really what matters is the medical decision making. I don't know that I saw that in the preamble, but I think that's part of what's going on. So basically, in 2 years, you'll be able to choose, all right? They're also going to create a couple of add-on codes. And these are G codes, and they're designed for primary medical services, where if a doctor is serving as kind of the main contact for a patient, it's kind of designed for primary care, but they recognize that it could be a specialist. And like the example that they use in the Federal Register, you're a cardiologist in a rural area and you treat a patient and you're handling kind of all of the patient's issues, their diabetes and the like. If you're the main doctor for a patient, you get to add this add-on code, and it adds a whopping $13 a visit. So there are 2 codes. They're sort of similar. One is for primary medical services, and the other is for a non-procedural specialist. Okay? They're also going to create an extended visit code. This is totally time dependent. And basically, the way it works is if you get enough time, and you can see the times on the slide, once you're above 34 minutes for an established patient, if you're talking about a 2 to a 4, you can bill it. If you go above 70 minutes, you can bill a level 5, or you can bill it for a level 5. So it's just a new code for what are kind of currently called prolonged visits. What they've decided is they don't like the term prolonged. They would prefer to use the word extended. Same idea. Here is kind of economically how things are going to work. Now, reimbursement, as you know, varies from state to state, so this is sort of a national average. And I guess the key thing to look at is that basically if you do what is now a 2, 3, or 4, in the future, for a new patient, you'll get paid about $130. So that's almost the midpoint, a little closer to a 3 than to a 4. For an established patient, you'll get $90, which is, again, a little closer to a 3 than a 4, but sort of between, you could call it like a 3.4 if on the scale, right? And so obviously this will hurt people who build lots of level 4s. It'll help people who have built lots of 2s and 3s. You can get this $13 add-on code, which throws stuff up a little bit. That's a bad thing to talk. Throwing up during lunch is a bad conversation test starter. All right. Home health visits. As of January, so the next changes we're going to talk about are effective now. So effective January 1, 2019, I guess in 2 weeks, not now, you no longer need to document or have medical necessity for a home visit. You can just do them, and it's really that simple. You don't have to assert or demonstrate that the patient is homebound. The teaching physician rule, this is a pretty significant change. Currently, there's a federal regulation, and you can see the site there, that says the physician has to personally document their involvement in an evaluation and management service. That requirement doesn't apply for procedures. For procedures, anyone who's in the room can document the physician's involvement. But as of today, the doctor was supposed to document his or her E&M work, which is why we have what's often called the attestation. Well, that's going away. And instead, the physician's involvement can be documented by a physician, a resident, or a nurse. Now, I was a little amazed that whenever a new rule comes out, there is a preamble where people can write in comments and the government responds. Apparently, a number of people were upset because they think this is going to result in a shift of work and responsibility from the doctor to the nurse or the resident. And that probably does happen to some extent, but apparently that really, some ire was raised for people who are like, why should we have to do the documentation? And CMS said, well, that's not really what we're focused on. So you have heard us probably talk about how if it isn't written, it isn't done is not generally the law. There are historically just a handful of exceptions, and this was one. Anesthesia is another. There's an explicit anesthesia documentation requirement. Well, this one just got eased. My next point is more of a question. I'm reaching out to CMS, something I don't do very often, because I want to understand what they mean to say here. Because I'm wondering if there's been a time change. And what I mean by that is historically, you get to bill for, if you're billing on the basis of time, if half of a visit is counseling and coordinating care, the test is you choose a code based on the typical time that CPT has, and you can round. We'll throw the CPT language up in just a moment, but it's really clear you can round your times. And so, for example, a 99213 requires 15 minutes. A 212 is 10. If you did 12 and a half minutes, you can round up to a 213. That is clear as of today. In the Federal Register, they have language that talks about how the physician will have to personally spend at least the typical time associated with the CPT code. You can see it here, and you can see it here. They're going to require the billing practitioner to document the visit was reasonable and necessary, and that they spent the current typical time for the code reported, and they here use the example of 15 minutes for a 99213. That is not true today. And I believe that really what they mean is that when they say the typical time, what they mean is if you had 13 minutes, you're okay and you can still round, but it's unclear to me. And so I think that'll be an important question to figure out, is whether have they killed rounding? And just to be clear that rounding is okay, here's what the CPT introduction says. The government also, they've done a number of good things, and here's one of them. They have made it very clear that doctors, nurse practitioners, whoever is documenting in the medical record, need not re-record information that's in there if they demonstrate that they have seen it. Now, this is super important. We've been saying this for years. I don't think this is a change. They describe it as a change. I don't know where that logic comes from, really, because if you think about it, this is just another quote saying the same thing. So these are quotes in here for you to read. But basically, they're saying you don't have to. You can still choose to re-record everything if you want, but you don't have to. People are skeptical of this, and they would say, no, a doctor has to record the HPI elements. I know that. And think about this. Before we had an EHR, how did information get into the medical record? And the answer, it was dictated. And when it was dictated, it wasn't the doctor who was putting the information into the electronic or into the medical record. It was a transcriptionist. And I've never heard anyone assert that that wasn't valid because the doctor has to put it in, him or herself. Now, I suppose someone could say, well, it was the doctor's voice, but that's not it. That isn't the test, right? The question is who has to put it in, and anyone can put it in. The patient can put it in. And I think that's always been true, but they've made that very overt here. Last slide, and I think it is now 12/12 on 12/12. So for those of you in the central time zone, happy double 12/12. What didn't they do? They talked about getting rid of modifier 25, which is what allows you to bill an evaluation and management service on the same day as a procedure, and they were going to possibly greatly limit that. That did not happen. There was talk of allowing 2 visits within the same specialty on the same day. And the thinking is that increasingly you might see like an internal medicine and a geriatric physician, or people who have the same specialty under Medicare, but different specialties in sort of is conventionally understood. Orthopedic surgeon and hand surgeon, right? Same Medicare specialty, but really kind of this, but very different. They have not done that, although they're looking at it. There's also talk of getting rid of a lot of global surgical stuff. They basically think that visits that are supposed to happen during the global period do not in fact happen. And so there's talk of changing that. That didn't happen. And then there was talk of new podiatry specific codes. The outcry killed that off. So I'm now going to turn it over to Catherine London, who I will just say is hip deep in clinical trial agreements and loves doing them. So if you've got a clinical trial agreement, call Catherine.
Thanks, David. So I'm going to first talk about some notable changes in the fee schedule that relate to virtual care and telehealth. And I talk about this topic every year, and usually there's not much to report. And that's because Medicare reimbursement for telehealth services is significantly limited by statute. And by way of background, telehealth services have to be provided in certain geographic locations and at certain types of originating sites in order to be eligible for Medicare reimbursement. However, this year, the Balanced Budget Act actually modified and removed some of those limitations for certain types of services that I'll talk about in a couple minutes. But first, I wanted to touch on some interesting developments around other types of virtual care physician services. And these are actually not subject to the limitations on telehealth, but instead paid under the fee schedule like other types of physician services. And the first new covered virtual service this year is a virtual check-in. And we have the codes on the slide here, but this first service refers to a physician's brief check-in with a patient using communication technology to assess whether the patient's condition actually warrants an in-person visit. So as of January 1st, this service will be separately billable unless it originates from or relates to service that's provided within the past week by the same physician, or if it leads to an in-person service with the same physician, in which case it would be bundled into the payment for that visit. So this is going to be priced at a lower rate than existing E&M in-person visits and can only be provided to established patients. The next new covered virtual service is a remote evaluation of pre-recorded patient info. And this covers situations where a physician uses video or images that are captured by the patient in order to evaluate the patient's condition. And once again, when the physician's review of the image or video actually results in an in-person office visit with the same physician, or if there's a related service provided within the past week by the same physician to the patient, then that is also bundled into the office visit. And then lastly, Medicare is also going to begin covering interprofessional internet consultations. Hard to say that one too fast. But basically, they'll be making a separate payment for consultations between healthcare professionals that are intended to treat a patient. And in these cases, the treating practitioner does have to obtain consent of the patient prior to billing for the service. Moving on to more traditional telehealth services, every year CMS adds codes to the list of services that are covered if provided via telehealth. And for 2019, CMS is adding 2 new codes that relate to prolonged preventive services. And CMS is also expanding access to telehealth for home dialysis patients by allowing individuals with end-stage renal disease who are on home dialysis to actually receive monthly ESRD clinical assessments using telehealth. And so this is one situation where the statute was amended to add a patient's home as a permissible originating site for purposes of these clinical assessments, and also removing the typical geographic requirements that usually have to be met in order to provide telehealth services.
And, I'm just going to chime in there for one second, which is because this is interesting. I think it's the Medicare Benefit Policy Manual that says generally a service is a physician service if the doctor can visualize any portion of the patient without the interposition of the judgment of a third party. And to me, that covers telehealth, right? And yet and CMS takes the position that you can't do telehealth, and there's a federal regulation on this. And this has given me a headache for, 10 years or something like that. And I don't have a magic answer to that one. I will just say this: if you ever get denied on a telehealth, that language in, I think it's the Benefit Policy Manual, is you can be your friend. I'm not advocating that as a position I would take prospectively, just in a pickle.
Good point. So the Balanced Budget Act also removed certain telehealth restrictions relating to acute stroke services by adding the mobile stroke unit as originating sites, and again, removing the geographic requirements that typically apply for those types of telehealth services. And then also through, it's an interim final rule with comment period right now, CMS is implementing a provision from the SUPPORT Act, which is the opioid bill that Margie's going to talk about a little bit later. And it removes certain telehealth restrictions and adds the home of an individual as an originating site for telehealth services that are provided for treatment of substance use disorder or co-occurring mental health disorder. So there are a lot of interesting, statutory changes here that have allowed expansion in this area that's been historically very restricted. Moving on, another change in the fee schedule relates to payment for Part B drugs. And in general, Medicare payment for separately payable drugs includes an add-on of 6% of the average sales price or wholesale acquisition cost for the drug. And this covers services such as drug handling and storage. And The average sales price is more common and net of any discounts, unlike the wholesale acquisition cost, which doesn't include discounts and is therefore typically higher than ASP. And starting next year, during a drug's initial sales period, when payments are based on the wholesale acquisition cost, the add-on will be reduced to 3% instead of the typical 6%. So CMS thinks these changes will improve payment rates and better align payments with the actual drug acquisition costs. I'm going to touch briefly on changes to the Medicare Shared Savings Program. CMS finalized changes to the quality measures in the MSSP by removing 8 measures and also increasing focus on outcome measures such as patient experience. And the final rule also provides a voluntary 6-month extension for existing ACOs with participation agreements that expire on December 31st of this year. CMS is also allowing beneficiaries who voluntarily align to certain clinician types to be prospectively assigned to an ACO if their clinician is participating in that ACO. And then lastly, CMS is extending certain policies to address the impact of extreme and uncontrollable circumstances on ACO quality and financial performance. Moving on to the Merit-Based Incentive Payment System, or MIPS, which was created under MACRA. And this is a system that adjusts payment based on provider performance in certain designated performance categories. And so for 2019, CMS is expanding MIPS to include new clinician types that were previously excluded, and also clinicians that were left out of MIPS due to the low volume threshold can now opt into the program. And then finally, CMS is also adding 8 new quality measures and removing 26 of them, which is part of CMS's effort to streamline documentation and reporting requirements, which I think Pari is going to touch on a little bit later as well. So the last few items I'm going to talk about from the fee schedule are on this slide. The first relates to payments for non-accepted off-campus provider-based departments. And as of 2017, certain items and services that were provided by certain off-campus provider-based departments are not paid under the OPPS, but rather under the fee schedule using a relativity adjuster. And for 2019, CMS has finalized that the relativity adjuster will match that from 2018, which was 40% of the OPPS rate. CMS also included a request for information relating to price transparency and improving beneficiary access to provider and supplier charge information. And the last point on the slide, CMS is revising its physician supervision requirements, so diagnostic tests performed by a radiologist assistant that would otherwise require personal supervision of the physician can now be provided under direct physician supervision. That's if permitted by state law. So I am going to hand it over to...
Just real quick, what's the difference between personal and direct for those? So basically, personal means you got to be in the room, direct is in the suite. And so this is a big change. I mean, I remember we've had a couple of big overpayments on there where if the supervising radiologist is sort of in the radiological area, that was not enough. They needed to be in the room. And now, so this is a significant loosening. Now they can be in the, I was going to say neighborhood, but we should be accurate, in the suite.
I'm now passing it over to my colleague, Pari McGarrett.
I'm going to talk a little bit about the inpatient prospective payment system and outpatient prospective payment system final rules. Between these two rules and their commentary, we're talking about 1,000 pages. So you guys are going to get the things that I think are interesting. First, I'm going to talk about the inpatient prospective payment system rule. So this rule was proposed back in May, and the final version was published in August in the Federal Register. Unlike some years when we get new substantive requirements, the theme of this year's rule in the IPPS is removing administrative and regulatory requirements. That's reflective of sort of a macro shift in policy under this administration. One exception is the area that Margie will be talking about related to opioid issues, where there's been sort of a growth in substantive requirements. So the highlights that I want to talk about, first is an overall increase of $4.8 billion for inpatient spending. Assuming that the hospital participates in the EHR programs and in the quality programs, that should be about a 1.85% increase. I'm going to talk a little bit about the Patients Over Paperwork and its sub-initiative, the Meaningful Measurements Initiative, because I think they're interesting. These relate to the quality programs. There's been some skinning down of documentation changes or documentation requirements, which is similar to what David had talked about earlier. And then there's been a clarification in policy on what CMS means when it directs hospitals to be transparent about their charges. First, I'm going to talk about the Meaningful Measures Initiative. This is a sub-initiative of the Patients Over Paperwork Initiative. And the sort of big thing that's happening here is that a bunch of quality reporting measures have been removed from various programs. CMS gave their criteria for removal of these programs. I think these are interesting because it's sort of a window into how they're making decisions. So measures that are duplicative, measures that have no meaningful distinction in performance. And by this, the agency seems to mean that hospitals are performing sort of uniformly at a high level. And so the measure is topped out. Query whether hospitals will continue to perform at high levels if they're not required to report. So one other sort of factor would be that the measure doesn't align with clinical guidelines or practice. That seems to make sense. That improvement on the measure does not improve patient outcomes. Seems like that makes sense also. And then this last one, which is sort of overtly business friendly, overly costly to maintain or report on the measure in comparison to the benefit of reporting, because that last category can see that there may be some benefit to having the data, but that it's not worth the price, as you say. This affects a handful of programs under the IPPS, the Inpatient Quality Reporting Program, the Value-Based Purchasing Program, the Hospital Acquired Conditions Program, although the removal of a couple of measures under that program are delayed until 2020, as opposed to beginning in this next year, and then the Readmissions Reductions Program. Across those 4 programs, there are 18 measures that have been completely removed, and another 25 measures that are being removed as duplicative of others. That's a pretty substantial skinning down of the measures. I feel like every other year that we've done this, I tell you that they're adding 2 or 3 measures. So this is different than we've seen in the past. I'm going to shift gears slightly, talk about some documentation changes. There are a handful of these. I've selected 2 to talk about because we have seen these be the basis of recruitments or audits. And so it's interesting that they are now less of a big, or not a big deal at all. One is the regulations used to provide that if physician certification is required, it need not recite all of the medical information that's necessary to support the certification in that same page, but it needs to indicate where that information can be found in the record. And the revision to the regulation this year is striking the regulatory requirement that the certification indicates where the information is to be found. The agency cited the searchability of electronic medical records. So the idea is that it's not that hard. You don't need the cross-reference because everything is word searchable now. The commentary does not include any comment on whether this reasoning could be applied to, say, audits that are already under review, for example. And this is issued and the commentary focuses both as guidance to providers and also guidance to medical reviewers, and the goal is to reduce the burdens on both by focusing on the content of the service, which has been a big theme certainly for David over his entire career, and less on the specifics of the documentation. So that's an interesting move that aligns with advice that we've been giving a long time. Similarly, the rule establishing when a patient is considered an inpatient for purposes of Part A payment has some documentation requirements right in that regulation at 412.3A. It used to say in the regulations these documentation requirements are a condition of Part A payment. So it's pretty clear, at least arguably, I guess, under the regulation, that you have to do the documentation or you may not get paid. The agency has struck that language in the requirement, so it's no longer an express condition of payment. And the commentary to this rule suggests even that the agency never really intended documentation irregularities to be the basis of a denial. They say it was not our intent when we finalized the admission order documentation requirements that they should by themselves lead to the denial of payment for medically reasonable and necessary inpatient stays. So what that tells us is that even for inpatient stays that have been challenged on documentation grounds that occurred prior to this change in the regulatory language, you could make an argument that CMS has explained that it never really intended for payment to be denied on that basis. The substantive standard for inpatient admission has not been changed, so the 2 midnight rule as modified by last year's rule, which is basically, is the patient expected to stay past 2 midnights, is inpatient level care medically necessary? That remains in place. And then finally, under the 2015 rule, hospitals have been required to make their standard charges available. There's a clarification of policy in the commentary this year that make available means make available a list of current standard charges via the internet in a machine-readable format, and that information needs to be updated at least annually or more often if appropriate. Excuse me. CMS has also issued a request for information for sort of input on how price transparency could be increased. They've highlighted concerns about surprise out-of-network costs, particularly for lab and radiology, things that states have been regulating for a long time for similar reasons, and unexpected facility fees. So maybe that's an indication there may be some federal attention paid to that issue, as opposed to doing it in the sort of state-by-state patchwork as we have up until this point. Shifting gears to the outpatient prospective payment system rule. This final rule came out just a few weeks ago in November, excuse me. The sort of highlights are it's an overall small increase. Most of the meat of what I'm going to talk about is on this site neutrality, which is provider-based, basically, updates. Obviously, we're going to dip into that a little bit more substantively in a couple of months here if we have some new guidance. So this is just focused on the narrow slice of site-neutral issues that were addressed in this rule. And then there's a parallel set of shifts under the Meaningful Measures Initiative for quality reporting programs under the outpatient prospective payment system rule. So site neutrality and provider-based, sort of macro refreshing. In the last few years, there's a focus on narrowing the availability of Part A payment or Part A level payment for provider-based departments off campus. CMS has articulated its core concerns as the same service should be reimbursed at the same level in similar settings, sort of getting at the idea that an off-campus provider-based department is not really all that different than a clinic and ought to be paid like a clinic. That's the agency's expressed position. And they've also expressed concern that having higher levels of payment for off-campus provider-based departments encourages consolidation and acquisition of physician groups to expand service lines and would reduce competition and, driving up prices is the idea. This all goes back to the Bipartisan Budget Act of 2015. You'll see this date pop up quite a lot in the provider-based discussion, November 2nd, 2015. That's the date of that statute. What this did is it removed off-campus provider-based departments from the outpatient prospective payment system and had them reimbursed under the Physician Fee Schedule. It grandfathered off-campus provider-based departments that were billing under the OPPS as of the date of the statute, November 2nd of 2015. As originally implemented, grandfathered space could still be modified or upgraded or add service lines without jeopardizing its grandfathered status and ability to bill under the OPPS, as long as the space didn't relocate to a new suite or number or address. And so in a lot of cases, it really came down to whether or not the post office thought you needed a new suite number. In the 2017 proposed rule, so that's now 2 years ago, 3, 2, I can count, 2, that proposed rule suggested limiting grandfathering to the clinical families of services provided as of the date of the 2015 Budget Act. That would mean no expansion of service lines, basically. That proposal was not adopted in the 2017 rule. The 2018 rule, so that's the one that came out last fall. Actually, I think it came out, doesn't matter, late last year. Did not contain a similar proposal, but this year's proposed rule that we're talking, that will go into effect for 2019, again proposed this same sort of limitation on grandfathering that would prohibit expansion of service lines. So grandfathered status would be limited to the services that were provided as of November 2nd, 2015. This proposal, again, was not adopted in the final rule, but the commentary continues to express concern about this issue. So what this means is that, at least for the moment, new service lines at existing off-campus, grandfathered off-campus provider-based departments will be paid under the OPPS, but that could change in the future. And based on these 2 prior rules, it's reasonable to expect that a change in the future would likely refer back to a baseline of November 2nd, 2015, meaning that in a temporary sense, you could get paid potentially under the OPPS, but that it probably would not affect the ultimate grandfathering sort of status of those new service lines.
And just one, this is hopefully stating the obvious, but I think we've seen over the years a lot of times where people focus on a proposed rule and sort of want to change based on it. And actually we'll hold most of our questions for the end, but someone asked, hey, could these E&M changes not actually happen? A lot can happen between now and then. And yeah, a lot can. And I think amongst the lessons, proposed rules are only proposed and final rules can still change. I mean, could stuff change before 2021? Darn straight. We would not pretend to be able to predict that. All we can do is kind of watch, but just it's helpful to remember that until something is actually in effect, it could still change. And frankly, with CMS, even once it's in effect, the retroactive change is not an impossibility.
And then there's just 2 more quick things on this provider-based site neutrality, which is even for grandfathered off-campus provider-based departments, the CMS has put in new rules that would cut reimbursement pretty substantially in certain areas. One is services that are coded under G0463. These are basically clinic services. CMS proposed that even in grandfathered departments, these would receive 40% of the OPPS rate, which is designed to approximate the physician fee schedule rate, i.e. to make payment for those kinds of services site neutral. In the final rule, they did finalize a version of this proposal, but it's going to be phased in over 2 years. So in 2019, you get 70% of the OPPS rate for those services, and in 2020, you would get down to 40%. This excludes dedicated emergency departments. And then another sort of area is last year, the 340B drug prices were pretty substantially reduced from an average sale price plus 6% to an average sale price minus 22.5%. That accepted off-patient or off-campus provider-based departments, and this rule will expand that cut to off-campus provider-based departments. Interestingly, these 2 cuts are not budget neutral, which means that they would represent a cost savings to the program, as opposed to lots of other times that CMS monkeys with payment rates, and the idea is that it's offsetting an increase somewhere else. These are not budget neutral changes. The 340B pricing issue is already subject to litigation on the theory that it is outside of the agency's statutory authority to do that, and I think that case was dismissed in September for sort of administrative law procedural reasons and then refiled recently. And then there's been some noise that related to this G-code issue. There would also be some litigation coming up.
So this might be a good, if you're listening to this like I am and going, God, this stuff is really hard. And I think Pari did a really nice job of making complicated stuff simple. My head hurts when I hear some of this. I want to put in a reminder that in the February webinar, most likely, Briar Andreessen and Katie Ilton will be going in depth into this provider-based stuff. It's at moments like this when I'm glad I'm surrounded by people smarter than I am. I'm also just going to put in a quick plug. We are trying, and I mentioned this last webinar, if we've got clients who are saying, hey, we'd like to be able to call you up with questions like, hey, can you just kind of describe this 340B thing for us quickly because we're confused by it. But can we do it like on a flat fee sort of thing? And so we've got some clients who are doing a flat monthly advice for sort of quick, easy to answer questions. And if you're interested in that, you can shoot us a quick email afterwards and we're happy to talk about that with you. That'll be our only pitch in the course of this. But we like answering the questions like this. It's kind of fun. All right, I think we got, we're going to Margie now.
I have one more slide.
I'll cut you off.
It's okay, it's not that exciting. They're also cutting a bunch of quality measures out of the OPPS for sort of similar reasons. So they're eliminating 9 measures for hospital outpatient departments and 2 for ASCs, sort of along the same trend that I described earlier, where we're trying to lighten up reporting.
So basically, I wanted to have poor quality by cutting you off early before you talked about the quality measures?
Yes, but conveniently, that's no longer a reporting measure.
That works, doesn't it?
Okay, now I'm going to pass it to Margie.
And so Margie, who's been up to her eyeballs in BPCI Advanced and a bunch of other stuff, is going to talk about something that snuck up on me, that's for sure.
All right, yeah, and I'm not sure it snuck up on everyone, at least the Support Act, but there is a very key provision in there which we'll talk about that certainly snuck up on a lot of us. And so I'm going to cover kind of some basics about the Support Act and then talk about some opioid-related regulatory provisions within the Physician Fee Schedule, the IPPS, and the OPPS. So the Support Act was signed into law on October 24th of this year. And if nothing else, you've probably heard about it as the new bipartisan opioid bill. The full title of the act is up there on the screen. It's the Substance Use Disorder Prevention that Promotes Opioid Recovery and Treatment for the Patients and Communities Act. But that is a mouthful, so we'll go with the Support Act. And this was touted as a comprehensive approach to addressing the nation's opioid epidemic, addressing treatment and prevention, recovery, and enforcement, kind of trying to take a very broad approach to addressing the opioid crisis. So the Support Act is 250 pages of legislation, which is way too much for us to cover today and in the last 15 minutes of the webinar. So we're just going to touch on a few provisions of note. Feel free to put your comments in the survey after the webinar if you want us to address kind of specific items in future webinars. So to combat the opioid crisis, the Act expands coverage under both Medicare and Medicaid for substance use disorder services. And there's an emphasis in both programs to cover that via telehealth services. And I'll cover Medicare provisions on the next slide, but for Medicaid, among other things, the Act expands Medicaid coverage for at-risk populations, populations that they see as particularly at risk for substance abuse issues. And then it creates a state option to cover up to 30 days a year of substance use disorder services in IMDs or institutions for mental disease. The Act is going to allow a broader set of practitioners to prescribe or dispense medication-assisted treatment, or MAT. They're expanding an existing waiver program that exists to include various non-physician practitioners, including clinical nurse specialists, certified nurse midwives, and CRNAs, as being eligible to prescribe MAT, and that's just for a period of 5 years while they assess that. And then it also increases the number of patients that given practitioners can treat at one time. The Act also expands reporting requirements for pharma and device manufacturers under the Sunshine Act. So starting in 2022, manufacturers are going to have to report on payments to non-physician practitioners as well as physicians. And I'll talk about that, the last piece on that slide in a couple of slides, because that's the part we're most excited and or concerned about. So one of the key Medicare provisions under the SUPPORT Act is the expansion of Medicare coverage to include medication-assisted treatment and those provided by opioid treatment programs, or OTPs. So these are currently services that most Medicare beneficiaries have to pay out of pocket for, but beginning in January of 2020, Medicare will pay for outpatient opioid treatment programs using a bundled payment model that will include payment for services like medication-assisted treatment, substance use counseling, both individual and group therapy sessions, toxicology testing, and other services that the secretary can define by regulation. In order to qualify as an OTP, programs will need to be Medicare enrolled, and they'll have to be certified by SAMHSA, the Substance Abuse and Mental Health Services Administration, and then also accredited by a SAMHSA-approved entity. As Catherine discussed earlier, one of the more interesting provisions is also the statutory change for telehealth services to remove that originating site requirement. So that's another biggie that was in there. But now on to, again, one of the most interesting and concerning pieces of the SUPPORT Act is the inclusion of another bill that was called the Eliminating Kickbacks and Recovery Act of 2018, or ECRA, is what I'm going to refer to it as. And the bill was designed to combat patient brokering activities in the addiction recovery and treatment facility space. And in its final form, ECRA establishes criminal sanctions for kickbacks with respect to services covered by any type of healthcare benefit program. So that's a key aspect of this act, which is that it covers both private payers as well as government payer programs, unlike the AKS. And it prohibits both the solicitation or receipt of remuneration for any referrals to recovery homes, clinical treatment facilities, and clinical laboratories. The penalties are fines of up to $200,000, imprisonment of up to 10 years, or both. And that's on a per occurrence basis. So we'll have to wait for kind of additional guidance to see how they're going to interpret per occurrence. So again, some of the key considerations and crucial aspects of ECRA is that it's going to apply more broadly than the traditional AKS in its application to all healthcare benefit programs. There is a caveat that they have to impact or somehow affect interstate commerce, but that is going to be likely the majority of plans. And then also it applies to referrals to those listed facilities, regardless of whether the referral is actually for substance use disorder treatment. So for clinical laboratories in particular, that may mean some very fundamental changes in their arrangements with their sales reps and other parties across all sectors.
So, Margaret, I mean, like we've got some clinics on board. I'm listening right now that provide lab services around the country. Do they need to worry about this? Yeah. So it's broad enough that you're going to have to look at all of your arrangements to make sure that they, if there is any sort of remuneration being exchanged, you are going to want to look at your relationships and make sure that they meet one of the exceptions, which I'll get to in a couple of slides. But yes,
I think it's broader than they intended. And I think there's a lot of hope at this point that additional regulation and clarification will come to kind of narrow the applicability of this. So the next couple slides are the text and of the main kind of prohibition here. And I'm just providing those to you guys for your reference so you don't have to go searching for them. So the statute does incorporate several exceptions of note. Some of them are direct references to the federal anti-kickback statute exceptions and safe harbors, but not all of those will apply in this for this act. So discounts to providers or other entities are permitted if they're properly disclosed. Also, if they are Medicare coverage gap drug discounts. The big one is compensation provided to employees and independent contractors. The exception is incredibly strict and narrow, so that compensation cannot be determined by or vary with the number of individuals referred to an entity, the number of tests or procedures performed, or the amount billed or received from the healthcare benefit program. So again, this one is particularly noteworthy because ECRA doesn't expressly exempt other forms of incentive-based compensation that would be permissible under the anti-kickback statute, such as sales commissions payable to bona fide employees or payments to GPOs or group practices. This is kind of the sole individual compensation exception that would have to be met.
So are you saying if a lab compensates an employee on a percentage of sales, that's a problem under this?
That's correct, yes.
And that seems, I mean, that's so inconsistent with the anti-kickback statute.
Yep, so it's, yeah, I think it's something where you're definitely going to want to take a look at your arrangements and make sure you consult with us or other legal advice to make sure that your arrangements meet these kind of very strict requirements in this interim period before hopefully we get some additional guidance and exceptions that will be a little bit more reasonable. So you can also have, they've incorporated by reference the personal services and management contracts safe harbor from the anti-kickback statute. There's also non-routine good faith waivers of co-payments and co-insurance. They've cross-referenced the federally qualified health center remuneration exception under the anti-kickback statute. They've also created a new exception for, or it's not new, but it's one that we don't see in the other areas, for alternative payment models. And then there is a explicit permission granted to the AG and to promulgate other exceptions to the broad waiver. Okay, so that's enough on ECRA. I'm going to talk a little bit about how this emphasis on the opioid crisis and specifically the Support Act played out in the new rules for 2019. Catherine already talked about this earlier, but this is one of the most significant rules to come from the Support Act, which is the removal of the originating site requirements for telehealth. CMS also made changes with respect to the MIPS program and includes opioid-related quality measures as high priority measures starting in 2021. So I put on the slide there, that is the kind of definition that they use to describe high priority measures, and you'll see it now will include opioid-related quality measures. They also added 2 opioid-related measures, which includes the querying of PDMPs, as well as a new measurement called the Verify Opioid Treatment Agreement. measure. All right, so the other big change that will come in the future is, again, coverage of opioid treatment programs. And in this final rule, they've just solicited comments on creating bundled episodes of care for management and counseling and treatment for substance use disorders. So more to come on that. The Support Act also prohibits the hospital consumer assessment of healthcare providers and systems survey from including questions about communication by hospital staff with an individual patient about the patient's pain, unless the questions take into account whether the individual experiencing pain was informed about the risks associated with the use of opioids. And this really stems from a concern that the presence of those questions was incentivizing hospital staff to overprescribe opioids in order to achieve higher scores on the survey. So they are now eliminating those questions, and they are also not going to publicly display the measures on the Hospital Compare website or the value-based purchasing program.
That's one we've talked about internally for a while. I was surprised to see this because we've talked about how that question likely was a factor, and I was surprised to see the world was thinking the same thing.
All right, another opioid-related adjustment in the OPPS. This one actually didn't come from a provision within the Support Act, but it came from a recommendation from the President's Commission on Combating Drug Addiction and the Opioid Crisis. And now starting in 2019, CMS will provide separate payment at average sales price plus 6% for non-opioid pain management drugs, for such drugs when they function as a supply for a surgical procedure and when that surgical procedure is performed in an ASC. All right, moving on to the IPPS. As Pari mentioned, the IPPS was published in August, which was prior to when the Support Act was enacted. So there aren't things that came or stemmed directly from the Support Act, but there were still some opioid-related measures. And one notable one is that they finalized 2 new e-prescribing measures within the Promoting Interoperability programs. And these mirror those measures from the MIPS program as well. So the query of PDMP measure, that will be optional in 2019, but then required in 2020. And the Verify Opioid Treatment Agreement measure, they decided after extensive comments to make optional for both 2019 and 2020. And that's due to a lot of concerns about lack of clarity in defining what an opioid treatment agreement is, how to track and find those agreements, or to actually document that they exist. And so the idea is to make them optional while CMS and the industry tries to figure out a better way of tracking that. All right, so those are the kind of notable items, and
we've got a few questions we'll whip through. I'll put in the reminder that the January webinar is on digital health and emerging healthcare technologies, January 16th. One more plug for if you want flat fee advice, give us a buzz. And now let's look at some of these questions. So one, what are the rules on time of regulation to time of policy manual update? And I think what this person is asking is, hey, the manuals sometimes don't say the same thing that the reg does. And that is very true. And the most amazing example of that was when the 2 midnight rule came out. I think it took 2.5 years for the manuals to catch up. I could be off a little bit, but it's pretty close to that. There's no guidance, and this is a good time to think about the principle articulated in the Brand memo, which came out almost a year ago, which basically says the manuals aren't the law, and that's Another state, this is another thing. That wasn't new a year ago. That's been true for forever. Manuals aren't binding. And we know this because the government has asserted in briefs that if you rely on information in the manuals, you do so at your own peril. Manuals aren't law. So how long will it take before the manuals catch up? We could gamble, right? We could do a little lottery.
Yeah.
We don't know.
They won't be updated before Pari has her baby.
That is true. We could actually.
No, I can say that with certainty.
We could do a pool on the manual and on Pari's baby.
Yeah, absolutely.
I think you've got one.
Sure. I have one question. Is there anything that indicates where the physician needs to be located to provide virtual care services? Can they be in their home? So again, virtual care is different than Medicare, what Medicare considers telehealth. And telehealth, there are a ton of restrictions on location for the patient and the practitioner. But from the virtual care service standpoint, CMS really hasn't stated anything about where anyone needs to be located. These are services that are provided via communication technology. And so what really matters is the type of communication technology being used. And CMS has stated, obviously, it has to comply with HIPAA, so there have to be adequate privacy and security protections in place. And CMS is also seeking comments on what type of communication technology patients and physicians are actually using and what practitioners consider to be kind of standard these days.
These site of service questions are really tough.
Mm-hmm.
It comes up primarily in radiology, right? Where is if the doctor is in a hotel room, what's the site of service? And the answer A has always been in manual, not regulation. B has evolved a heck of a lot. And most currently, they kind of recognize that if it's someplace that's temporary, you can kind of ignore it. And when I say temporary, I mean like a hotel room, you can ignore it. But I would say this is not the kind of thing I would ever refund on, but trying to get it right is worth it. There's at least one more question here. And Margie, do you have? I've got a weird one, which is what about agents and employees that are paid a commission for selling a health insurance plan? I didn't mean to insult that question. I guess it isn't weird. It's one that I don't deal with a lot. Lori Hartman is our best plan person, and she is not in the room at the moment. I would say that's a totally different critter. Generally, under anti-kickback land, anything you do with an employee is okay, and that's part of why what Margie said was so significant. This is the first time employment doesn't save you in a kickback setting. But health insurance is its own world, and I'm not an expert. I'd look to Lori Hartman for that. Is there another? Did we just get another one? All right, I think so. Remember to follow us at Fred Health Law on Twitter. I don't know how to do that.
This is new to all of us.
But I will ask Breyer to try to put some jokes in, and trust me, if you follow, it will be worth it. She's got the only Christmas card in the world that strangers like reading.
True, I read it out loud to my mom every year.
I do too.
She's already talked about you, David, on the Twitter feed.
Oh
so
God!
You should,
all right. Well, hopefully.
If nothing else, look for that.
It's actually one of the things we were wondering. There was so much about Google yesterday, and what word, what word would describe you. If there were a word that you would search that would bring up an image of me, it would be messy. I think. Or maybe, yeah. Or maybe really bad sense of humor. But in any event, okay, so January 16th, Ryan Johnson. On February 13th, we think outpatient provider-based rules. And I think that brings us to a close. Well, thank you guys all for listening. Oh, just remember, you will get a link to this. If you want to have one of your colleagues suffer through it, you can send them the link. It's free, right? You can just forward it to them and they can listen to it. Dan usually has it up, sometime Friday or Monday. And so like if you ever have to sign off in the middle, you can listen to it later. So thanks for listening.